Hello, everybody, and welcome to the first episode of the NF podcast. I'm Klaas Röhl, the founder of NF Patients United and the head of the Austrian organization NF Kinder. I have a daughter who was diagnosed with NF1 when she was just a child in 2010. That's when my involvement began. At the time, there wasn't any Austrian patient organization for neurofibromatosis and just a few European ones who weren't connected at all. That's when I decided to found NF Patients United and bring all member organizations together. But that's enough about me. Today we have a very special guest that I would like to introduce to you, Matt Boltz Johnson. Welcome, Matt.
Hi, Klaas. Nice to be here.
Matt, you hold a Master of Art in Fine Art at the University College in London and worked as a production designer before changing your career in 1999 when you started working in an acute mental health unit in London. And you worked 14 years in a National Health Service, the NHS in London, being a hospital manager in Mental Health Trust and as a health commissioner. So you were responsible for setting up the different NF services in the UK for NF1 and for NF2. And then you joined Eurotis in 2014 as a healthcare and research director and later becoming a mental health lead and healthcare advisor. At Eurotis, you had led advocacy for rare disease community by shaping the development and delivery of European reference networks. And specifically, you also ensured a patient-centered approach is at the heart of the ERNs through developing European patient advocacy groups. And you also lead the advocacy work on mental health, the Mental Wellbeing Partnership Network. So you have done amazing work over the past years. You've been very busy. So before we dive in, I want to ask you the first question. Matt, your career path is quite extraordinary, as I just elaborated on. Why did you leave the career of arts and product design and got into the health sector?
I suppose it's not really a traditional career path, and one which probably in other countries like in Germany is not really a standard way to train in one area and then move across into another, especially so different from the arts to health. But I was doing a PhD and I took a bit of time out from doing theatre work and I wanted to have the summer in London. And I got a temping job in a St Mary's Hospital in Paddington. It was a mental health unit for adults. I was a bit nervous, and my mum, as I always say, my mum gave me two bits of good advice. I can never remember the first one, but the second one, she said, when I talked to her about the Mental Health Trust, she said, do it. You'll learn about humility and humanity. And I did it, and I absolutely loved it. I loved working with the clients, supporting them, and I saw how a system can institutionalize people. And so I stayed in health, working in the Mental Health Trust, and really utilized my creativity in the health service, and my creativity I use in my everyday even now to help design services, develop strategies. So they're very transferable skills, surprisingly. I always have a joke about collaborating with an opera singer and trying to get her in a dress she doesn't like. It's a bit like working with pediatric neurosurgeons. You know, it's transferable interpersonal skills and making people feel comfortable and maybe having a different perspective. And I think that's why I think I've done well in health, is because I bring a different skill set, which I think was missing, and I've never regretted it. I love working with the patient community, and working in the UK NHS really gave me a lot of experience, especially in my national commissioning role, where I first came into contact with rare conditions or ultra rare conditions like neurofibromatosis type 1 and type 2, and once you connect with those communities, it's hard to step away from them. They make you feel welcome, and you learn so much from them. They're inspiring people to collaborate with. So yeah, not a typical career path, but I've loved every minute of it.
Fantastic. I just realized we have another thing in common, because I was trained as an engineer and now I'm a patient advocate. So that's also not a traditional career path. So you joined Eurodis in 2014. For those listeners who are not familiar with the work that Eurodis does, can you maybe talk a little bit about that work?
So, going back, Eurodis was founded in 1997, and at the time, certain patient groups like the haemophilia community and the cystic fibrosis community were well developed because there was a critical mass of cases. But for a lot of rare conditions, there was, the individuals affected, the prevalence is really low. So it's easy for health systems or policymakers to focus on the 99% of the need of the population. And those individuals who actually are affected by some of the most challenging disorders fall through the cracks and are easily ignored. So what Eurodis really did from when its conception was to be a focal point for all the people affected with a rare condition to come together, to connect. Some of those individuals then set up patient groups, and you started to see the critical mass of everyone living with a rare condition. So Eurodis, I think, was a catalyst, and NORD in the National Organization for Rare Disorders in the US, I think they were also about the same time. They really brought together a community to be seen, and now we can say there's 300 million people living with a rare condition around the world. That's hard for policymakers to ignore. So Eurodis really is an umbrella community of over 1,000 patient groups in 74 countries. And it's been a community which I think, you step into and you see remarkable leadership and endeavors where people step forward and, retrain and learn how to engage with industry, push research through, so you end up with new therapies going through clinical trials for their conditions. You see extraordinary achievements from the rare disease community, and I think that's so inspiring. And the whole of all of the public health areas can learn from rare conditions.
Definitely. There's so much to be learned in rare diseases, so many unanswered questions still to be discovered. I just thought about how I met you for the first time. That was in beautiful Ljubljana, Slovenia, at a conference around the Cross-Border Healthcare Directive, which was basically what now the European Reference Network are based on. Can you talk a little bit about your role in setting up the European Reference Networks, especially the one that is responsible for NF, the ERN Centuris? So
I left the NHS and moved to Brussels, and Jan was one of the first people, Jan Nakam, I met, and Enrique Terol at the Commission. And basically, my national commission role in the UK was setting up national services or networks for ultra-rare conditions. So I had some experience of getting my hands dirty on how to set up a network, a clinical network. What's the value in it? Where is there aspects which have real value and benefit, and where is it a complete waste of time? So, and Jan saw that experience at a time when the ERNs were just an idea in the legislation. We hadn't even got the delegated decision, the legislation to set them up. So I started with Eurodis when that idea was in the legislation, and Jan hired me, and I worked on the ERNs for the last basically 12 years. And really the first thing we did as a community, so in what the Cross-Border Healthcare Directive did was there was always cross-border collaboration in research, but never in healthcare. That's the sovereignty of each country. And what the Cross-Border Healthcare Directive did was set the precedence that it's fine and okay for cross-border voluntary collaboration between member states in rare diseases with the ERNs. And so that space of collaboration in health, in rare diseases, never happened before. And the ERNs were being set up in that space. So we saw it, and Jan was great. He always pushed me to think big, and it's amazing when you think big what you actually can achieve. It's quite remarkable. So the first bit of the implementation of the ERNs by the Commission, who they were responsible for, was to do a call to set up a project to have a consortium come together to develop the assessment framework, the application process. And Jan being Jan, he said, let's go for it. So I worked with the Canadian organisation, and Eurordis was the lead in terms of the contract, and we put in an application, we won it. So in this space, this, I want to say, versional space of collaboration in healthcare, you had a patient group leading the way, defining what level of expertise is needed and what an ERN looked like. So that really set the precedent, I think, where all the clinicians looked at Eurordis and what we were doing and saying, what do we do here? And of course, the work which we did in the joint action highlighted that actually with rare diseases, there's scarcity of cases, but there's a scarcity of experts. So people living with a rare condition are experts by experience, and they should be involved in the networks, in the rare disease networks. So by us leading this project, setting up the ERNs, we were able to put at the heart of these applications patient-clinician partnership, which never had happened before. And the blueprints, the application forms, some of the coordinators have said to me, we didn't know what a network did, but by completing the application, that formulated what our understanding of what the network should achieve. And one of the networks, which was ERN Gentauris, had come forward, and it was an open call. Whilst we expected a skin network, a metabolic network, there wasn't one model which was put in the call for applications. And the genetics community came together and pulled together an application for genetic tumour risk syndromes, which wasn't expected. So we ended up with 24 applications going to the board of member states when I think they expected 12 or 14. And, because of my experience with working on and setting up the UK and F1 and F2 services, I understood the complexity of these conditions. And so Eurordis gave a voice in the application process and called for all member states to see this as a landmark moment in history. And this is a decision bigger than each of them individually. There wasn't one right approach, and whether it was a big network, a small network, a network focusing on specialties or one focusing on tumours. We called for all 24 networks to be approved, and they were. I mean, I think 24 is a perfect number. We have a brilliant system, and globally, everyone looks to what the ERNs are doing, and it's innovation. And we're leading the world in this space, and it's great.
Fantastic. And they have done so much so far, using their motto, share, care, and cure, to develop clinical guidelines, for example.
The magic, I think, which doesn't get seen about the ERNs is when you get the clinicians for a condition, let's say neurofibromatosis type 2, coming together and talking and sharing their experiences of care. Each of those clinicians, whilst they're brilliant individually, together they know more, and when they walk away, their understanding of the condition and what to do has been enhanced. So the care which they give locally then is informed by the collective knowledge of the network. And I think that's really levelling up. And I think it's magic. It's absolutely magic. I get goosebumps whenever I see the clinicians talking to each other. They're not that bothered, but I am. I think it's what's at the heart of the networks is this knowledge generation.
Absolutely. And I think it's clear by now that you have a talent in setting up network, and another network that you are critically involved in setting up is the Mental Health and Mental Wellbeing Partnership Network. Just recently in 2023, can you talk about this initiative? What are the aims and who is involved?
So working with the patient communities, the EPAGs, the European Patient Advocacy Groups, we over the last 8-9 years, we developed patient journeys which mapped the needs of the community for individual conditions. And I think we worked on over 50 of them as a team, and maybe even 60. And every time we worked on them, the message came up about mental health and well-being and the impact these conditions have on not just the individuals, but the whole family. But then when you look at our advocacy, there was no advocacy around how do we live well with a rare condition? How do we provide emotional support to families? And it really struck me that that was a massive gap. I conceptualize rare conditions and the impact it has on mental health and well-being in one of two ways. We live in one of two spaces, as it were. You're either firefighting the medical complexities of a condition, looking for research to push for treatments, trying to find someone who knows to get a diagnosis, getting access to a treatment which is available, or we're alone. And it's when we're alone that that emotional impact of that journey hits home. And no one should feel isolated living with a rare condition. And that's the power of the patient community, being connected into a community. All of a sudden you start to break down that social isolation. But our advocacy, since your audit was set up, focused on those medical complexities, diagnoses, research, access to treatments, and over recent years, moving more around holistic needs and integrated care. But that whole dimension about the psychological impact it has on families and how we can counteract those risk factors and put in protection factors to people going through that was something which was missing. So the board, we said when the European Commission did highlighted that mental health was a priority for them, a public health priority coming out of COVID. We said to the board of Eurodis, this is a big issue for our community, and they all went, yes, absolutely. So it became a priority, and just by doing that, I think it made people feel in the community that actually I'm not alone. I can say when things are difficult. And the network, the mental health network, which we've set up, is really to give space for people in the communities to step forward who have faced these challenges, which are very natural responses to very extraordinary situations. When you get to giving a diagnosis, your whole world changes. It would be unnatural not to be affected by that. So the network gives the space for our community to step forward and connect, to be seen, to support each other, and to know that your mental health matters. And I think that if people know that and that they're not alone, we can start to improve their lives and all our lives, and we all benefit from that. So we set up the network, and we've been doing a number of activities under that for the past couple of years, and we've been doing a communication campaign about putting a face to rare conditions, people explaining their real world experiences as a personal testimony. So we really see how these going through that very challenging pathway for diagnoses and treatment, rare diseases is associated with, that we get to see how that impacts on people's lives. And I did a workshop with the OI community in Oslo this year, and it was absolutely brilliant to be in their space where people felt safe and to talk about the importance of looking after ourselves and that they matter and these things are important.
While the over 7,000 rare diseases are so different from each other, there's so much overlap when it comes to dealing with uncertainty, living with a rare disease that doesn't have a cure yet, feeling isolated, feeling like an outcast of society, dealing with discrimination. So there's so much common topics that affect mental health and rare diseases.
I almost think that mental health as a term becomes a stigmatizing term where people then they don't associate that's them. And actually, if we could refocus it and say, how do we look after the quality of life of people living with a rare condition, to live well with a rare condition? What does that look like? That removes the stigma associated with it. And that workshop in Stockholm was brilliant. We had over 100 people there. I've never met one patient community who said this wasn't important to them. And we need to give space in our communities to talk about it. And there's simple things we can do to improve quality of life now, like access to trusted information, being connected into a patient community. Not everyone is. I was told by someone from the tuberous sclerosis community when they first connected with a conference on tuberous sclerosis, they said it was a game changer. All of a sudden, they were seen, their experiences were legitimized. They didn't have to explain. People understood. There was people further down the pathway or journey, as it were, who they could talk to, and it helped. And having a patient group, we talk about psychosocial care, which is basically to make sure that we don't just address the physical needs, but we think about the resources families are able to cope with difficult treatment pathways and stuff like that. But the foundation of psychosocial care, I think, is the patient community. And it's so underrated, it's so not visible how important. If it's one thing from this podcast, if you are in a patient community, knowing that your community exists, know that that is a game changer. That enables people to be connected. They don't need to say how they feel. They're in a space where they feel safe, and they understand that there's other people who understand them and what's going on in their lives. I think that is something we need to hold more value, and not get lost too much in pushing research and other things. Just by being in existence is a game changer, and is so a lifeline for lots of people in your community.
Absolutely. You mentioned the interdisciplinary, multidisciplinary care that is so important in rare diseases. And for some time, it was very much focused on the medical aspects. But now I think more and more healthcare professionals, also doctors, come to the realization that psychosocial care is equally important. I think something that also patient advocates have been talking about for many years. And I think people start listening now.
So let's just break down what psychosocial care is. That's not having a psychologist in the team and handing over to them anyone who has any difficulties. Psychosocial care is basically ensuring that all medical care and treatment is psychologically informed, that we enhance any interaction with someone living with an F1 and F2, that whether it's a nurse, a surgeon, a geneticist, the language that they use, their approach is more is enhanced to being a bit more thinking about the individuals as people, making sure that they're there and checking that they're okay, not just giving them complicated languages or languages where it's sort of biasing, saying what can't be done instead of what can be done. How living with a condition impacts quality of life, but our beliefs, our perceptions, how we perceive the condition adds another layer of complexity and can colour our understanding of the condition and can impact quality of life. So our beliefs and expectations around a condition are shaped by how other people talk to us about that condition. So how your doctor talks to you about NF1, what's possible, what's not possible, can empower you to see the condition in a way that isn't one where you are anxious, or there's a level of uncertainty which will always be there with rare conditions. It's not handing over to a family a diagnosis, that uncertainty, and say, there you go, get on with it. As a clinician should hold the responsibility of that uncertainty and provide support to those families and saying, we don't know all the answers, but over the next 6 months, these are things which we can do, which gives structure and certainty in an uncertain environment. That's psychologically informed care. And I don't think that costs a lot. And I think, we can start to change that. So over time, I think this is starting to take root, and people's understanding that there's needs there to modify how medical care is given, which is cost effective.
Absolutely. And anxiety is a very common issue in rare diseases as well. And this can also impact their healthcare if they are just too afraid to go and see a doctor, even though they might experience symptoms. This can be life-threatening.
Anxiety is clearly associated with uncertainty. So if you manage the uncertainty of a condition has by getting access to timely information which is trusted, you don't look on the internet for stuff, that it's managed in the right way, then you can reduce the level of anxiety around living with that condition. But it's having the information in a trusted way at the right time. And one of the things about as patient communities, the people living with a rare condition, because that uncertainty creates a thirst for knowledge and information. And so, like yourself, you do more research, you do more reading. But by doing that, you create other possibilities in your head. So it's a bit of a double-edged sword that needs to be managed. So that's why having access to curated, trusted information at the right time is absolutely key. You don't just get it all at once.
I sometimes feel that the multidisciplinary teams that look after rare disease patients need to counter all the negative effects that rare disease patients experience in society. They often deal with discrimination. They feel like outcasts. And when they should feel compassion and empathy from our society and feel like valuable parts of society that they are. And like you said, people can learn so much from rare disease patients. They are often role models when it comes to resiliency and dealing with huge challenges that most people couldn't even imagine.
So people living with a rare condition and their families are the most resilient people I've ever met. A little anecdote, I travel a lot, and I got to Amsterdam late on a Saturday night on the train. And of course, I leave my bag with my wallet and all my passports in, my 2 passports. I don't have that many. And I got to the hotel and realized it'd gone, but my life. And I went in meltdown. A really nice lady from the chondroplasia community, she came to my rescue, a knight in shining armor, and she had my back. She got my bag back. I mean, it was incredible. It was like she was a magician of some type. In a crisis, people in the rare disease community have become really good at dealing with that survival mode. But what's really important is that survival mode doesn't become a reality, a normality. We need to be able to go back to living a life. And so support's needed definitely from multidisciplinary teams in that respect, to always check the family's resources, how they're best able to cope with the current treatment plan which is going on or what's going on in their lives. So we definitely can do more there to put in some protection factors for families and reduce some of the pressures so people can step out of survival mode and start living again.
Mm. And what would be like one policy change that would have a big impact on mental well-being in the rare disease community?
It's a big question. If you are affected by cancer and you go through the healthcare service, let's say in Austria, psychosocial care is an integrated part of your medical care. There's a brilliant guideline actually on that in Austria. If you live with a rare condition, psychosocial care isn't there. It's not an integrated part, but the needs of people are the same. So if I did have a big wish, it would be that there's greater recognition of looking at the needs of people with a rare condition, mental and services, physical health services, become more psychologically informed, and that becomes a part of their day-to-day business.
That's a great wish that I can totally support.
You support it because you have set up in Austria, and this is why I always get inspired by what NF Kinder does. You've set that service up. You have a clinical service, an expert centre for NF, which has the psychosocial support system there. If you can do it, class, surely is it too big an ask for health services to do that themselves?
I'm sure that health services can learn a lot from patient organizations because what we can do with a relatively small amount of money, I think, is astonishing. But yeah, let's keep connected to the health services and show them our best practices. I think that's where they can draw a lot of inspiration from. Matt, you are now living in Cologne. What was the biggest cultural shock that you experienced also in terms of the health care services?
Well, the biggest cultural shock would be Carnival in Cologne. That's very clear. But in terms of the health service, I sort of been experiencing different health services around Europe, and I think the elective care services in Germany are really, really great. You have a good level of care. It's a short time to see someone, just because it's elective, it's not emergency. It doesn't mean that people aren't, it's not urgent, as it were, or severe. And that's really, really good in Germany. Emergency care struggles in Germany, whereas actually in the UK, it's the opposite way around. Elective care is always really fun. The income hospitals have really goes on managing the trauma rotas and stuff like that. So, there's no one perfect health system, but there's benefits to all of them, and we need to create greater learning across those different systems.
Also another thing that the year ends probably can help a lot with.
Yeah, absolutely. I in the UK, because I'm also got my UK passport, I suppose, the UK is really innovative at coming up with new specialties or professions. So we have things called gypsies and pixies. So they're GPs with special interests or pharmacists with special interests. So there's a real diversification of roles to meet the needs because of the financial situation with the health service. I see less opportunities of diversity around that in other countries. And so we definitely can learn between each other in terms of health systems and how they work and what works best.
Great, Matt. It was a pleasure to talk to you. I think we covered all the questions that I had, and thank you for your insights. It was truly inspiring. So this was the first episode of the NF podcast. I hope you all enjoyed it as much as I did while producing it. If you have any questions or feedback for Matt or for me, feel free to reach out to us. You can find our contact information in the show notes. Thank you for listening, and until next time. Thank you for being with us, Matt.
Thanks, Klaus.